Wonderful. All right. Welcome, everybody. Here we go. We're going to talk about mood disorders and violence. They don't necessarily go together, but they're organized for that way for our purposes here. This is one of the most common situations you will encounter as a psych NP and even in primary care. So it's important that we figure out how to identify the different kinds of mood disorders. So the main objective is going to be that you can distinguish mood disorders. How do you not over medicalize things that are, sadness and grief? We don't want to medicalize normal behaviors. So we're going to distinguish from dysthymia, cyclothymia, major depressive, bipolar 1, bipolar 2. We'll talk about different types of violence, physical, sexual, child, and elder. And we'll talk about suicide and homicide risk assessment because they think that you have some magical power about you to tell if someone's going to kill themselves or somebody else. And no one has told them that we don't really have those kinds of tests in psychiatry. All we have is what the patient tells us, therapeutic alliance, collateral, and corroboration. That's all we got. I don't have anything else to tell them the likelihood of that. He said he's not going to shoot anyone now. He said he's not thinking about shooting anybody. He does have guns. But lots of people have guns that don't shoot anybody. What's your risk assessment? Well, depending on the state you're in, it seems that your risk assessment will be different. So that's the objective for today. So demographics of mood disorders, prevalence, it's the leading cause of disability worldwide. It shows up in a bunch of different ways. People can manifest these depending on their culture in different ways. So some people will have a lot of somatic complaints that when you do a workup don't tend to yield anything. Impacts physical health, work, relationships, quality of life. About 15% of major depressive disorder people die by suicide, and it doesn't make it any better for you to realize that most people who kill themselves have seen a mental health provider within the preceding 30 days. It also doesn't help that most suicides post-discharge happen in the first 30 days. It also doesn't help to know that as you start to feel better, your risk of suicide also goes up because you suddenly have the energy to follow through. Women are twice as likely to develop it. I think that's because they're also twice as likely to access healthcare. So that's how you capture that data. If you don't come to care and if you don't fill out my survey, I have no way of knowing that. Recurrence rate is about 60% after the first episode, 70% after the second episode. There are separate ICD-10 codes for, single episode, first encounter, recurrent, remission, partial remission. You can look up all those ICD-10 codes for when the time counts, but just suffice it to say, depression can resolve. Now, most of it, believe it or not, will resolve spontaneously within a year, whether you do anything or not. Something to keep in mind. Not all depression necessarily needs to be treated with a psychotherapist. Some people can effectively treat it with life and coping mechanisms and, social supports and friends and neighbors and different types of mental health coaches, counselors, pastoral care, your rabbi, your minister, all of those people are working kind of in the field of mental health. So that's something to keep in mind. Now, the other thing you can keep in mind is depression and mood symptoms can develop at different stages. In other words, it could be a stage of life due to things like, say, hormonal fluctuations, situational stressors, things like that. Why do I say that? Because that 5P formulation that I keep coming back to that I want you to ingrain as your comprehensive way of doing a physical or a psychiatric evaluation, I need that to be very much a part of your systematic approach. Meaning, those first 6 steps, rule out factitious malingering, rule out substance-induced, rule out underlying medical condition, right? Rule out an adjustment disorder, which is these situational triggers that may lead to mood symptoms. Step 5, pick a primary psychiatric disorder. And step 6, oddly related, just not your norm, does not make it a mental disorder. That's the process. Now, how do you take that history? I keep driving back. you need to consider what are the predisposing factors, precipitating factors, perpetuating factors, and protective factors in the domains of biological, psychological, social, and I would even add spiritual to that, because someone who is having an existential crisis, challenging their faith, that could be the trigger that suddenly launches them into this moment of despair. Who might have that? Maybe somebody raised in a very fundamentalist household, suddenly goes away to college, differentiates, discovers a worldview that is not like their own, and then they're suddenly questioning everything they've been raised with, but that's the thing that they've used to make sense of their life, and suddenly it's been taken away. So that is the person that may be the adjustment disorder. But if it persists longer than the 6 months and their coping mechanism are gone and their primary social support network maybe came from their community, be it church or otherwise, that person may be in a longer term and qualify for major depression, or if it perpetuates dysthymia. Bipolar disorder combined, all subtypes, about 1.5% of the population. That's like bipolar 1 and 2 combined. There is a high morbidity and suicide risk, and this requires accurate diagnosis. This is often misdiagnosed and often mixed with borderline personality disorder. So there is a pejorative to the diagnosis of borderline personality, which we'll talk about in the final week about personality disorders. But suffice it to say, you can organize personality disorders as long and enduring behavioral and psychological characteristics that have been adopted in order for that person to survive whatever period of time that that disorder may have developed in. Why do you cause drama? Why are you splitting? Why do you why do you cut yourself and try to draw attention? What are you doing? What they're doing is trying to control the world through them, right? We'd say it's primitive, it's not developed, there's hope for further development, but that often gets misdiagnosed as bipolar because the mood keeps fluctuating, right? So people, oh, they call it rapid cycling. They've gotten crazy in front of me within the span of a day. Okay, if someone's having all kinds of moods in the span of one day, that's not rapid cycling. That's not how mood works. Rapid cycling is those 4 episodes within the span of a year. That's a lot, right? Span of a year. Not, I feel great by breakfast, by dinner, I'm crying. Tomorrow afternoon, I'm laughing hysterically. That's not rapid cycling. That's personality, that's character. That's not what we're talking about here. So in the inexperienced arm, that's how that gets mislabeled and misdiagnosed. So there are many theories as to what causes this. Today, as we go through these, what I want to do is beat out of your head so that you never say the word again, neurotransmitter and chemical imbalance, okay? Don't want you to think that. That's what we used to do. That's not what we're doing now. So I'll go through it so that you never say the words serotonin, chemical imbalance, here's a pill, it might work. It might not, it doesn't work half the time, and we'll tell you more later. Okay, so depression, complex interplay of factors, like we said, life stressors, no single cause, multiple biological things. So this genetic predisposition is interesting. The problem with this is it does not necessarily, because there's no depression gene. In fact, there's no single gene for any of these mental illnesses. So the question is, it's a bunch of genes, and some are on and some are off. And the gene does not necessarily express unless it's in the right environment, which we call that epigenetics, right? The environment acting upon the genetically predisposition such that it can manifest itself. So for example, with alcoholism, if you are genetically predisposed to alcohol use disorder, if the environment does not provide alcohol, you don't have a way to manifest alcohol use disorder, right? You may use some other substance, but specifically alcohol, that one is not going to get turned on if the environment is not conducive to it. Brain chemistry, in theory, affects this. Biopsychosocial influences during vulnerable life periods. New to college, new to motherhood, new to fatherhood, new job, lost a job, grief, despair, etc. Those are the biopsychosocial predisposing and sometimes precipitating factors that trigger a mood disorder. The thing that keeps it going, the perpetuating factor, which is where all of your interventions are going to be aimed, right? Those perpetuating factors are where you're going to help. That may mean plug back into your social group. That may mean take care of your medications. That might mean go to the gym, hydrate, get proper sleep, etc. Those are the perpetuating factors that are depleting the psychological and physiological reserve that they have to get over this hump. You can't change what has happened in the past. That's the predisposition and the precipitant. You can't change that. So just aim your interventions at the perpetuating factors. Okay. So the chemical imbalance myth, why this persists and why it's wrong. So first of all, this is the most common myth perpetuated in psychiatry. Psychiatrists say this all over the place. It's a very clean, tidy narrative. It makes sense, but it's also false. So the idea came from early observation studies in the 1950s with an antihypertensive medication called riserpine. And they were giving this medication, and what it did is it depleted serotonin from them. This crossed the blood-brain barrier, and they found that these people got depressed. And so this was the theory, because it was an adverse effect of the medication, that made people believe that therefore your depression is caused by depletion in this neurotransmitter. In reality, there was no consistent evidence that people actually have less serotonin in the brain, and we also have no test to measure it. The other thing is, when you take an SSRI, your serotonin goes up in a matter of hours, but your depression symptoms don't seem to go anywhere for, say, 4 to 8 weeks. Right? We tell everyone 6 to 8 weeks, maybe 12 weeks. So if serotonin were truly the causative factor, if you think back, wrong class, to determine causality, you have to consider proximate interventions to outcomes. So that is to say, if I put this here within a few hours, say the half-life of the medication, I expect to see a physiological response. Well, that doesn't really seem to happen. So why don't they feel better for weeks? What seems to happen is the brain learns to adapt and reconnect and rewire. So depression is not so much this deficiency in one chemical as much as it's a disruption across the whole system. And then that's the thing that affects appetite and sleep and emotion and thought. But what you also have to remember is the longer you've been in a particular behavior, the longer you don't sleep well, the more that becomes habituated, right? So right now my knee hurts and it wakes me up at 2 o'clock in the morning every night. The problem is it's been going on for 3 months now, and even though I take pain pills and the knee doesn't hurt, I have habituated waking up at 2 o'clock in the morning every night just because my body's used to this surge of pain, and it's almost anticipatory pain that I'm getting, right? So if you imagine that this continues, I have low mood, therefore I don't eat, I don't sleep, I don't, and that continues for a period of time, even though we put the neurotransmitters in and we allow the brain to adapt, that process takes time. It's not instantaneous. So depression, like I said, is not a deficiency in one chemical, but a disruption across the system. So I want to help you develop the narrative or the script that you can tell patients. So this is the medicine that caused all the trouble. And there's the study by Healy in 97 that said, hey, that's a book actually. So if you're looking for a book to read on the subject, The Antidepressant Era, by Healy, by all means, from 1997. So Prozac came on the market in the early 90s, and we've debunked that bioamine or biogenic amine theory of serotonin and depression almost right away. But it was a clean model, and it came to market, and so people bought this and kept telling it to each other. The myth lived on. This observation formed the foundation of the chemical imbalance theory. So the thought was if you deplete the monoamines, it caused depression. So the theory was if we increased it, maybe that could treat it. And this took off, and it gave psychiatry a biochemical foothold. And unfortunately, what it did, as much as it brought a lot of drugs to market, it greatly delayed psychiatric research because this was the only acceptable thing that people were willing to listen to. So this drug supposedly provided it and provided the theory for that. This drug, which was used for high blood pressure and psychosis, for active agitated psychosis. That's what it's no longer on the market. So that's why you can't find this drug anymore, because it did make a lot of people depressed. It did cause a lot of sedation. It didn't do what we were hoping it would do. But this is the drug in the 1950-55 that caused this to give rise to the theory. So this serotonin depression umbrella, this is a study done by Montserrat, and you can look up the study and you can just snap a picture and read it. But this is an umbrella study, and this was probably one of the most comprehensive done as recently as 22. And they looked at multiple systematic reviews and meta-analysis, right? So it was a study of studies. Okay, and across every area they looked, whether it was serotonin levels in the blood or serotonin in CSF and receptor availability, they looked at tryptophan depletion. Not one line of evidence consistently showed that people with depression had lower serotonin. So the sample sizes were massive, because what they do is when you do a meta-analysis, what do? You pool the sample. So if you pool the sample, that takes into account everyone that's been enrolled in every trial. And so that's what makes this significant. And there was no statistical or clinical evidence to show that serotonin deficit was the culprit in this major depressive disorder. So the theory is unsupported. They keep coming back to it, but it continues to hold on. And so what happens, though, unfortunately, serotonin and depression, and this guy did a study. This is by Lacassie and Leo, and essentially the disconnect between advertisements and the scientific literature. So I tell you, and I tell every NP group I come into contact with, please do not tell your patients that this drug is for what the commercial says it's for. The most basic example, for example, is H2 blockers, right? Pepsid and the like. And it's an H2 blocker for reflux. The problem in you can tell that to the patient if that's what it's for. The problem in you understanding it that way is you miss the actual mechanism of action and what else it can do. H2 blockers block histamine, right? So that is why you may prescribe an H2 blocker off-label in an allergic reaction situation. So you may give an antihistamine, which would be like, cetirizine or diphenhydramine, right? That's the antihistamine part. Well, what do you do with the histamine that's already floating around? You need something to block the receptor site, because if you don't, the histamine hits the receptor site, you continue to have symptoms. So antihistamine is preventing the release. The histamine blocker is blocking the receptor site. But if I hand the patient Pepsid for an allergic reaction and you don't teach them, and they think this is for heartburn, that NP doesn't know what they're saying, you're bad. You see the problem? So it's important that you understand the medications from the mechanism of action perspective, not from what the advertiser told you it's for. And that becomes especially true in psychiatry, because we do a lot of off-label, right? We don't actually have a drug approved for any personality disorder. We don't have a drug approved for dysthymia, cyclothymia, adjustment disorder. There's no drugs approved for that. Technically, the FDA says those are for major depression, bipolar, et cetera. So this paper essentially compared what actual literature says to the advertising, and they find a total mismatch. So the ads all suggest that serotonin is the cause of depression, but the peer-reviewed studies, like the previous ones I showed you, show no evidence to support it. So the review basically says what is in the media is not matching the literature. So this is where your responsibility as APRNs pops in, and your patients deserve a better explanation. So what might you possibly say to them? So let me just finish up here. This is a study by Kirsch. They looked at 35 clinical trials, meta-analysis, another one. So their pooled sample was over 5,000. And what they found was for patients with mild to moderate depression, the difference between antidepressant and placebo was statistically insignificant. Question? Yeah? Question? No? Oh. Yeah. So mild to moderate depression, statistically insignificant. Yes? SSRIs, SNRIs, et cetera. Yeah, yeah. Oh, yeah. Yeah, TCAs, all those. Because we don't have a biochemical theory in mild to moderate depression. Question? Right. So where does it work? It works in major depression, like severe depression, severe symptoms. So when you do the psychopharm lecture, you'll get a whole day on mediators and moderators. But mediators are the intended effect of the medication. That's a mediator. A moderator is all the reasons that it may or may not work. It may work too good or may not work at all. Those are all things like age and sex and pregnancy and predisposing conditions and et cetera, et cetera. All those things that are substance use disorder, all those things that are generally cut out of a clinical trial, because when we're enrolling in a trial, I want a clean sample with not a lot of variables to get this response to show that it's better than placebo so I can bring the drug to market. So only in severe cases of depression did the antidepressants show a clinically meaningful advantage. And it wasn't because, say, the drugs worked better. And the other thing you need to keep in mind is this whole placebo and nocebo effect. If you believe you're taking it and I think it works, well, what are we dealing with here? We're dealing with how you feel in your mind and your cognitive distortions and your reality. That's what we're dealing with. If I tell you this will help, and it helps, and you're helped, you know, who's going to say yay or nay? But that being said, you need to keep in mind that you should not underplay lifestyle modifications. You should not underplay things like exercise, hydration, nutrition, and sleep, and social interaction. Don't underplay those, because those are the moderators in their life that will determine likelihood of a good outcome. And if you focus on that, you'll build therapeutic alliance, which is the only predictor of a successful outcome. So what do we do now? Well, neuroplasticity. So BDNF theory of depression. So depression is not a deficit. It's a serotonin disruption in the brain's ability to adapt. So depression involves impaired neurogenesis. So this is how you may communicate this to your patient. The idea here is that depression is not just about chemical levels, because we don't know what they are. It's about what chronic stress and emotional trauma may do to the brain and function. So specifically, it impacts the brain's ability to adapt and form new connections. So this is the whole now where all of our research is focusing on BDNF, brain-derived neurotrophic factor. This is essentially what's called miracle grow for the brain. It's not a pill, it's something your body produces. And so when we give those SSRIs, SNRIs, et cetera, what we're doing is we're fertilizing the ground to allow this growth factor to be produced. And what this is supposed to do is create new synapses. This causes neurogenesis. Think of it like therapeutic stress. I can cause you to develop a new way of doing something and develop a new pathway in a variety of ways. If you come in and I stress you out every week, what happens is you become desensitized to my stress if I point and call on you every week, right? And your brain can do a couple of things. It can either shut down and your mind goes blank and you just don't talk to me. That's your freeze response. You can rise to the occasion and be free to talk back and give me the wrong answer and keep leaning into your fears and leaning into your deficits, and yet you become more confident because you are growing. If you keep doing that, the brain develops a new stress response, right? If you keep facing your fears, they're no longer fears, right? Confidence builds. Confidence is not a feeling that just happens to you. Confidence only comes by doing. You have to do the thing you're afraid of, right? What are you afraid to do? I have one patient right now that's afraid to use the locker room because he's afraid that he's like morphic about his own body. It's not really. He just has never been around a locker room of naked men because he's under 30 or 40 or whatever. And so the conundrum becomes, it's like, I can't do it. I'm like, you just need to do it. He's like, I can't. Well, you're never going to be confident in using it if you don't. So you just kind of need to. And he's like, nobody said anything because nobody cares. Turns out nobody's looking, right? He's like, oh my God, I had all this drama in my head and these cognitive distortions. But if you lean into the fear, then you kind of get over it. Now we're working on driving. I'm like, go take your book test. You're going to drive. I'm afraid you're not going to get better until you drive, right? This is the whole failure to launch phenomena. Parents who have paved the road for their children have basically said, I don't trust you. I'm undermining your autonomy. You'll never amount to anything. And I'm therefore going to do all these things for you because you've never risen to the occasion. right? Same thing here. You've all been nervous. Oh my God, they're going to call on me. I have reading to do. Yes, but what's happening is you're doing it. You're doing the reading. You're coming to class. You're taking in the material. You're facing your fear of having to speak publicly. So these chemicals you put into the system, and essentially you are causing neurogenesis. So the typical avoidance behavior that we do, the same rule applies: use it or lose it. So if you don't lean in and your body says, oh, we don't have to do that anymore, then you lose the ability and it atrophies and that part of the brain shrinks. And so what we're saying is if we give you this chemical fertilizer to set the stage for you to be able to do all of those moderator factors, lifestyle, et cetera. So what we're saying is this is and by the way, if we're saying 6 to 8 weeks, that's what we're explaining to you. It's going to take 6 to 8 weeks for this chemical stage to be set. In the meantime, I need you to lean in. I need you to do the thing you're afraid of. I need you to practice the sleep hygiene, the hydration, the nutrition, the physical exercise, the go to the fitness class, go meet a social interaction. You have to do the work. That's the therapy. You bring them back every week to adjust the dose, make sure they're not having adverse effects, and to hold them accountable for doing the therapy. Then getting dressed and coming to you may be the therapy that they have been laying in bed and avoiding for so long. So just the act of coming, having a conversation, 45 minutes of intense eye contact, that could be the therapeutic stress that is helping them adapt and move forward. So other treatments like exercise, psychotherapy, ketamine, things like that, those are all about building neurogenesis. That concept is called neuroplasticity. We used to think what you got and you're done. No, it turns out you can learn. It might just take longer, right? And it will take longer depending on how long you've been symptomatic. So what do you say to the patient? Well, here you go. You're going to reframe your explanation of medications. So this medication will trigger a cascade that increases BDNF and will enhance synaptic growth. This will reverse some of the stress-induced atrophy that has developed in your brain as a result of avoiding and not doing. And hopefully it sets the chemical stage for you to do the things you want to do. Because right now you're governed by your feelings, and we need you to be governed by your logic. And sometimes we need behavior to overdrive it. I don't feel like getting dressed. Get dressed anyway. I don't feel like coming to the appointment. Come to the appointment anyway. And what you'll read, it's like, I don't feel like working out, right? What do? Go to the gym, just start, and then it comes along. You may not do the best workout, but you'll still give yourself credit for doing some workout. And then the next day you'll be less apathetic because you're breaking through that atrophy. Other treatments that increase BDNF include exercise, ketamine, psychedelic-assisted therapy, psychotherapy, PBT, especially because of mindfulness, and ECT. Basically, what we're doing is we are putting things in the brain that are going to force it to adapt. Now, this psychedelic-assisted therapy is not FDA approved. It is still illegal, technically a class 1 drug. This is where the research is going. The problem is half-lives and late effects and reversibility. So you have to be careful to first do no harm before you blanketly recommend. Yes? On their own, likely.
Well, are they going to universities and do research? Are they doing clinical trials?
Anyone doing psychedelic therapy legally needs to be in a research clinical trial. Yeah, there is no prescription to Walgreens for, no.
No, I mean,
No, I know, but there's the ketamine, yeah, the ketamine is another, the nasal spray, the infusion centers, the lollipops, the lozenges, the stickers, that's coming 100 different ways with ketamine, yes? It's increasing your own production, right? We don't have a BDNF pill. Because we just now came along to BDNF, we were lying to each other about serotonin for years.
Nootropics, which
right?
I feel like fits into this category as well. So I mean, there's not, there is.
There is and there's not. And the problem with that whole market of nootropics is that we don't exactly know what's in the substance because they're not held to the same pharma standards. So what you find is a lot of that stuff winds up, and we'll do a whole lesson on this in Psychopharm, but all of that winds up on the GRAS list. GRAS meaning generally regarded as safe. And what's in it doesn't have to be exactly what's in it, and the fillers and binders. And I don't know what's getting through first pass effect. I don't know does this stuff survive the GI system and the liver, or does the liver detox it sufficiently, you really are getting nothing? Is there a placebo effect in the fact that you've paid enough and you think you're taking a pill and you're really hopeful and that's what's doing it? That's the kind of stuff that needs to go on to say, yes, it's worth $60 a month for this supplement or whatever. You know what I'm saying? So those are the things that we have to consider. Yeah. So talking to patients, we're not fixing a chemical imbalance. We're helping your brain become more flexible and resilient. Okay, that's your new tagline. This is the new script. No more we're fixing a chemical imbalance. Okay, we're just helping your brain become more flexible and resilient to overcome that atrophy. Okay, okay. So, questions thus far? Okay, we're enhancing neuroplasticity. Another word you could use, yes? Yeah, but what's happening is the brain is trying to get to homeostasis, right? So essentially, whenever you put something in, the brain has to work now to restore you back. So what you're doing is you're just forcing the different brain sections, the synapses, essentially to either fire more, which is if you put in a stimulant, right, you'll pump out the dopamine and the norepinephrine. If you inhibit reuptake, the brain will have to adapt to the new chemical environment. So really what you're doing is you are, in theory, therapeutically disrupting the chemical environment in order to cause neurogenesis. And that neurogenesis over time is going to hopefully lead to you willing to do the lifestyle stuff. Okay? Yeah.
If an antidepressant boosting serotonin, the same way that you take it, doesn't improve your mood, then why does depleting it through MDMA cause that depression?
That was what Reserpine did when it came to market, right? That depleted actually the serotonin across the board. People are getting very sedated, apathetic, and withdrawn. The problem we run into is we don't have a normal serotonin level per se. And I think the MDMA essentially boosts and suddenly drops off. And I think what you're reacting to is the precipitous drop. So my suspicion is on some level, it's not the depletion as much as it's the acute withdrawal. That's my theory on that. I mean, I'm not the biochemical engineer who's researching this, but my theory is that whenever you ectopically supplement something, say with Ritalin, right? People give Ritalin for, I have apathy, can't concentrate, I have no energy, I have whatever. If you take Ritalin, you will all focus, right? Whether you have ADD or not, you're all going to focus. You're going to have that energy. Life is not so drudgerous. You'll continue on. Now, if you get used to that, say 2 weeks, 3 weeks, whatever, then I suddenly stop your Ritalin. Stimulant withdrawal is apathy and no joy and no motivation, and I just can't do anything because you're used to it. The treatment essentially is a long washout period, 2 to 4 weeks. Not microdoses. You want the body to learn how to reproduce its own dopamine and norepinephrine. That's the conundrum. It's very similar to cocaine withdrawal. There's no cocaine withdrawal protocol. It's a stimulant. It's out. It's done. You're just going to feel bad for the next 2 weeks. Right. But no one wants to feel bad, right? Our society as a whole has very low distress tolerance. No one wants to feel bad for any reason whatsoever. And we have labeled all suffering bad. All suffering is not bad. Suffering is essential. It's vital to life. It's the only way you and your patients will grow and develop. There is no growth and development without suffering at all. Suffering at the gym, suffering on your diet, suffering because your mother's a whatever, suffering because the teacher's too whatever. You're growing as a result of the suffering. If it was all wonderful and umbilical cord and everything on demand, there would be no real growth and development. That baby suffers because it's too tight in here. I need to come out, right? But if it stayed tiny and first trimester sized and no one was getting bloated, this little parasite could live forever, right? Life is suffering, and your job is to help your patients suffer well. All right, so genetic factors in depression, so strong hereditary component. And the conundrum with that is Did the gene cause it, or was a parent, say, depressed and it became a learned behavior? Hard to tell. Hard to tell, right? This is how so-and-so acts. So maybe if I identify with so-and-so as a parent, and I think this is how I have to act, and so perhaps it's a learned and habituated behavior. So that's one of the problems in doing genetics. There is obviously twin studies, higher in concordance with identical versus fraternal twins, right? But you realize, did they grow up in the same environment, right? And did they equally learn it? Did they learn from one another? Are they emulating each other? Multiple genes involved. There's not a single causative factor. So just to point out the fact that this is complicated and it's more than meets the eye. So endocrine dysregulation and depression, this is a popular concept. It's not completely unusual, but the fact of the matter is it can be a downstream effect. This could be the process of atrophy, if you will, that I was talking about earlier. So this prolonged cortisol release in the brain, in theory, due to stress, it leads to fatigue, sleep disturbance, appetite change, because some people eat more and some people eat less. And when we talk about atypical depression, we'll show you that. And depressed individuals normally show higher levels of cortisol. However, cortisol also normally fluctuates throughout the day, right? Should be higher in the morning, lower in the evening. Acute things before the cortisol can cause it to surge, including the needle stick, including walking into the doctor's office, including the fact that you're worried about the test you're going to have. All of these things can surge your cortisol. So cortisol, while important, is not bad. Realize we make cortisol. Why? To deal with stress, right? If you don't make enough cortisol and you come to the hospital, we may give you a stress dose of steroids because I need you to overcome the stress I'm about to put you through, be it surgery or whatever. Something to keep in mind. Okay. So structural changes in the brain. This is not like, aha, on the MRI, there it is, therefore depression. No, this is theoretical along the lines of neurogenesis, right? This is, it's gone on so long, this part of the brain that would normally deal with that has atrophied and shrunk, right? But what's the problem? Who comes to you with a baseline MRI or scan of the brain? I don't know if it was always that size. I don't know if it shrunk. It's theoretical that it would make sense that if you don't use it, you will lose it. And depending on the brain of the brain that gets atrophied and it controls, say, your impulsivity or your motivation, that's maybe where we will see the deficit. Can you do anything about it? No, this is not neurology. It's not all about the brain. All of those lifestyle things are more than the brain. So this was the neurotransmitter theory of depression. Because these neurotransmitters, specifically serotonin, norepinephrine, and dopamine, they are the ones we're primarily concerning ourselves with when we're dealing with mood disorders. Neurotransmitter levels alone do not fully explain depression. And we don't know, interestingly enough, if it's the depletion that caused the symptom or the symptom caused the depletion. Kind of don't know. We don't have a baseline. We're doing correlation. And correlation is not causation. And I need you to keep that in mind, especially when you read any psych studies. You need to ask yourself, is this truly a cause and effect or correlation? The big correlation debate we have going on now is what? Vaccines and autism, right? So the vaccine came to market in the 1950s, right? And we typically diagnose autism somewhere between 18 months and 2 years of age, right? And we normally give the first MMR vaccine at 12 months of age. And so all we have to do is say, oh, look, time. Time was the only constant. They got the vaccine at 12 months. We diagnosed autism at 15 to 18 months, which is normally when we diagnose autism. And then what do we say? Well, it's going up. It's going up because why? What changed? The definition got broader. More people were aware. More people came to light. More people kept asking questions. We didn't give more MMR vaccine. The same 2 doses is what we got, right? Same thing. This is the problem when we mix up correlation with causation question.
It's not like 5 kids in the UK.
Right. Suffice it to say, it doesn't matter how small the study was or how poorly executed it was. We're rehashing the same problem. And this is the problem with bad research. It's when they take correlational studies and try to present them as causation, right? You can't do that. The only thing, like if, for example, You'll get this in psychopharm as well, but basically the only constant is if you measure two things over time and it changes, you're saying because these two things happened at the same time, therefore they must have caused each other. They just could be two independent phenomena. All right, circadian rhythm dysregulation and depression. This is a common symptom. Circadian rhythms is your 24-hour clock. This affects sleep, energy, mood, and hormones. And the biggest problems we have with depression is you will find these three sleep complaints in depression. Either the older people, early morning awakening, right? I wake up too early, 4 o'clock, 5 o'clock in the morning, wide awake, can't sleep. The younger people, difficulty falling asleep. Right? Give me the Ambien. I drink. Give me the Xanax. Those are your younger people. And then excessive sleeping is the hypersomnolence. This is your middle-aged man. You know, passed out on the couch, sleeping much of the day, avoidance behavior. So essentially what you're trying to do in this condition is you want to reestablish the circadian rhythm. Well, we make our own melatonin from the pineal gland. It's a 24-hour rhythm. It just doesn't happen when you're ready for sleep. It starts early in the morning. So this is why if you are going to behaviorally treat a sleep disorder, you start with what? Bedtime or wake up time? Wake up time. You start with wake up time. You want the wake up time to be ungodly early for them. And you want to stretch the nighttime sleep. So we'll say, I need you awake and out of bed by 6 a.m. and you're not allowed to get into the bed until midnight, no matter how tired you are, and no napping. Also, in the morning, I need you fully exposed to light, sunshine, get outside, all of that. What we're doing is we're trying to reestablish a circadian rhythm. That's why we say in the evening, after 5, 6 o'clock, dim the lights, no blue light, right? We're trying to create this normal clock. Longer you've had the sleep disorder, it takes just as long to fix the sleep disorder. So now, there are psychodynamic theories in depression. These are all the theories that you may see in psychoanalysis and whatever. These are all theories. There is no way to test these things. The way a theory works in psych is I offer you one of these explanations, and you sit there and think, do I identify with that? Does that make sense to me? Yeah. Okay, let's operate under that theory. That's all, right? The big one is aggression turned inward. This is very Freudian. You know, Freud's like, oh, all suicides are a double murder. And you need to look at who they intended to find the body as the true target of their aggression. So like if they kill themselves and then they make the mother or the father find it or the sibling, that's who they're really mad at. So they play all theories. Can I prove this? Not a lick. This is the stuff that has guided psychodynamic psychotherapy over the years. It could be you could be in a depressed mood because of your stressful living situation. That too could be true. And it very well could be you're in an acrimonious relationship. It could be, I don't know, maybe you're projecting on someone, or all of these psycho theories are possible. Suffice it to say, what do you do with it? Right? You can have long conversations about it. Some people would say that might make it worse because you keep rehashing and ruminating and fixating. There are some cognitive theories. So depending on how you organize your worldview, you may believe that you have a lack of control over circumstances. This is your victimhood mentality. Everything just happens to me. I have no control. Everything has bad happened. Everything bad will happen. And this can lead to you being passive and negative. And this habit of mind is what may be driving your, what we would call depressed behavior pattern, right? And this is kind of what CBT bases their treatment for depression on, looking at undermining those cognitive distortions with the hope of you moving forward and overcoming them. Environmental factors. Look, we have had violence and poverty, neglect and abuse since the dawn of time. These are not new. Okay, we have had this. We are more safe now in our modern era than we ever have been. Our life expectancy is far higher. We are more food secure than ever. We're not out hunting and gathering. You can dial a chariot on your phone and groceries, and they will all be delivered. We are in a time of utter abundance compared to if you think about the dawn of human civilization. Right? We have time now to think about things like therapy and psychiatry and mental health and well-being and wellness care, etc. Right? If you go into more impoverished, more underdeveloped areas of the world, you will find less of this. Why do you find less of this? Because we need to focus on survival. So when the focus is no longer you and how you feel, and you get to focus on survival and the practicality of the situation, a lot less, I feel bad, I can't go to the gym, my hair, whatever, you have less, right? So that's an element to keep in mind, especially when you work in such a diverse place like Manhattan or Queens, where you have people from all over the cultures, and how you organize depression and mental illness is very Western. It's very affluent. It's very Western Europe and United States focused. That's how the DSM is, right? That is where the power, the influence, and the pharma companies are aimed. So that's why we have this organized framework. So here are some risk factors for postpartum depression. So again, poor marital support, lack of supportive social network, negative attitude towards pregnancy, strained partner relationship, isolation, unplanned personal fears, and feelings of guilt and inadequacy. Do you have a pill for any of those things? No, there's no pill for those things, right? All of these things are moderators. All of these things can affect how you organize around yourself in the we'd say postpartum. The new word is going to be antepartum now. Postpartum depression's out. Antepartum depression is in. Basically anything around the pregnancy, from the time of getting all the way through 2 years after having, all of that is antepartum, around the time of pregnancy. So these are the feelings you can have this pregnant or not, but now we're doing this in the setting of hormonal fluctuations. And so this may be how you diagnose the situation. The circumstance helps you diagnose, right? Because if the mother comes to you depressed and she happens to be pregnant or happens to have recently given birth, because the way the DSM is organized, you have to label it an antepartum depression. And you're supposed to think that I need to be mindful that this person may develop bipolar down the road, just because the state they happen to come to you in. Yeah, but be careful labeling bipolar, because that's a very sticky diagnosis. It doesn't go away. Sure, yeah, antepartum fits in as well. And that then becomes another problem. If this pregnancy was strongly desired and took a lot of what I call GYN gymnastics to occur, and you lose it, well, now you have to contend with grief, right? And grief would be normal. We don't want to pathologize a grief response. So you have to be really careful in throwing those labels around. So here are some psychosocial factors that you can look into with respect to depression and mood disorder. These would be the predisposing and possibly precipitating factors that you may elicit in a history somewhere. And these are obviously because they've occurred or they are what the die is. You can't undo these. Now, life stages and mood disorders. For adolescents, hormones are fluctuating. You can have hormonal changes. They can be more sensitive. Lately, if I say anything about my 12-year-old girl's hair, I'm an evil person, right? I look like I pissed her off. I don't know why she's curt with me. We were lovey-dovey 2 days ago. Today, the world is ending, and I'm, I go from saint to Satan in a matter of hours. I don't know what I did wrong, but suffice it to say, and it changes, and she'll be sweet as pie. And I'm like, hey, see this? Knock it off. Can't keep doing this. Because if I let that go on, what happens? You can habituate that behavior. You can cause a character defect where someone thinks it's okay to act this way because you feel a certain way. And so if I don't nip that in the bud and say, hey, your feelings are not a reasonable explanation or excuse to act this way, because the world does not care about your feelings. Because if you piss somebody off because you were in a tiff, for whatever reason, you've still pissed off that person who may be your boss, your teacher, your employer, your friend. So you need to contain this and realize that if you need to be in a tiff, go take it where you can have your situation. When you come out here, I need your game face on, because we're dealing with the world. Yes, does it happen? It's normal. Is it real? Yes, it's real. Her feelings are real. The hormones are real. but we are still responsible for our actions. Same thing happens, especially in adolescence. The identity is developing, the body is changing, academic pressure, social media influence, if you let them have it. So there's a lot of reasons, precipitants or predisposing factors that can set the stage for your mood disorder. Bullying is another one, peer rejection, early drug alcohol exposure. Look, bullying's been around a long time. I think the bigger problem we have is every problem is focused and magnified, right? Without the 24-hour news cycle and your iPhone, you don't know what's going on in California and the war in Ukraine and the war in Gaza. And you don't know that you're being picked on and made fun of for your shoes or your hair on social media from your school. You didn't know. You went home, the news went off, you thought all what's in this house is all that matters, right? So you flipped on the TV and only news click on 30 minutes and that's all you knew. But now you have constant exposure, there's no getting away. So those are moderating factors that are causing depressed mood. Talked about postpartum, hormonal fluctuations, lack of social support, mental health. The other thing to keep in mind is pre-existing maternal mental health before the pregnancy happened, right? Especially if they are being treated and then you have to change or take off medications. And then, of course, the next stage of major hormone fluctuation, perimenopause, right? So it's hot, it's cold, I'm irritable, don't touch me, I love all of that, right? And then the other side of it is, my baby's leaving. And then do I want to have another kid because the nest is becoming empty? Or do I get a dog and treat the dog like a kid? And then the dog is now maladjusted. And then, of course, health and physical complaints. These also can factor in to psychological well-being. Part of your job will just be to provide anticipatory guidance. Look, what you're going through is hard, but it's normal. A lot of people are going through this. I'm here for you to support you. If you find that you're not eating well, not sleeping well, anhedonic, etc., we can try a little bit of medication to enhance neuroplasticity, to make you more flexible, because the older you get, the more rigid you get set in your ways. One of the true marks of mental illness is mental rigidity. If you pay attention to mental rigidity, they can't adapt. They can't take in new information for whatever reason. It might be too traumatizing. It might be that their worldview is so organized that this has become the religion of their life. And that could be something as simple as germ phobias, mask wearing. It could be as simple as beliefs about washing the chicken versus washing raw meat, right? Whatever the reason, they've organized around that mental rigidity, which could be like culture bound. You're not going to shake that because it's rigid. So when we say we're adding these medications to enhance flexibility, that's kind of what we're doing. You may be less ruminative over the germs, so I'm not going to wear gloves all day long or masking all day long. It may make you a little therapeutically apathetic about maybe contracting a bug. Because in the old days, we would just wash our hands, right? And Purell wasn't everywhere. So those are some things to pay attention to. Questions? No? Okay. Yes.
What is it? Is it postpartum psychosis?
Can be. I mean, if it proceeds long enough or becomes severe enough, you can indeed have postpartum psychosis. Sure. Yeah, absolutely. Look, the thing is, you're talking mood disorders, right, in the general sense. Now, that's not to say we don't treat them, and these can get very bad. You can get psychotic. You can become dangerous to self and others. I'm not telling you not to treat them. What I'm trying to help you to understand is this is all on a spectrum. And sometimes it can be as simple as anticipatory guidance. Sometimes you need to up the ante with lifestyle interventions. Sometimes you need to go as far as putting on medications. Sometimes you need to go as far as involuntary hospitalization. It's just a spectrum. And what I want you to know is there's a lot of variables that you need to consider. So they're coming to psychiatry because you've got 45 minutes to 90 minutes to get the life story and tease out all of these variables. They walk into primary care in 15 minutes. SSRI, here you go. Why? Because I don't know what else is going on in your life. I don't got time for all that. They say this pill going to help you, whether it helps you with neuroplasticity or balances your neurotransmitters, because that's what I learned 20 years ago. Here you go, take it. And that's it. No support, no follow-up, no accountability, etc. So that's Oh, that's possible too. And mood disorder could develop here and it could get really severe. The cognitive distortion is really bad. Yeah. So here we go. It's important that you have this psychosocial framework for taking in this type of history. This is kind of what it looks like here, right? Predisposing, precipitating, perpetuating, and protective factors. Your main interventions are going to be something as simple as psychoeducation for high-risk families. You might want to connect them to community support groups. Just be careful because disease-focused support groups, while helpful, can also be maladaptive and codependent. Like even something as established as AA, you will find sometimes, and patients will tell me this, that it becomes a competition of who can tell the most shocking story. Right? Who can tell, it becomes a competition of past traumas sometimes. In the sexaholics groups, that even gets to be a double-edged sword because as they're telling their narratives, other people are getting ideas. You did what, where? Oh, but try that. Right? So you have to be careful. It's not uncommon for people with anorexia to go to Overeaters Anonymous to get all the tips as to how to avoid food. So you have to be careful. And if they're doing groups or support groups, you kind of want to have some interaction where you can help shape the internal narrative. So the main goal is you always address the biological needs first, then psychological and social components thereafter. Basically, what I'm telling you is, you remember Maslow from your undergraduate? Don't forget him here either, right? We go after sleeping and eating first, and then we go after suicidal, homicidal ideations next, and then we deal with love, belonging, social support, what you want to be when you grow up, et cetera, right? So when it comes to medication, they're only working on biological factors. Now, this is a chart here to show you what perinatal depression might look like compared to postpartum blues. Postpartum blues, there's no pill for this. Postpartum blues, you know, a transitional mood disorder, but not rising to the level of necessarily needing a medication. Very short-lived, usually just a few days up to 2 weeks. Postpartum blues typically begins 2 to 3 days after having a baby, usually within a week or two. This is where you panic, like, oh my God, they gave us a baby. Like when we had our baby, it was like, we could take this thing home. You don't even know us. We're just going to carry this baby out of the hospital and that's it. It took more effort to adopt a dog from a shelter. But because she pushed this out, this is ours and we get to go home. It's our life. We don't know what the heck we're doing. And I work in healthcare. I just stare at it for the first 2 weeks. What are you doing? I'm watching the baby. Why? I don't know what it does. Looks happy. It's not dying. Making sure it's not dying. But of course, this wretched thing is going to disrupt your sleep. Right? And you're going to be sleep deprived after going through major trauma, and you're expected to care for it and feed it with your body. Yeah, you might be a little irritable. It's not completely unreasonable for you to say, I hate this baby, right? And we're going to help you say, yeah, but it gets cute. In fact, I think it's cute as a survival instinct, because if it was ugly, we'd kill it. But it's even the ugly ones are cute to the mama. And so you take care of this thing and you try to have someone support you and you try to find someone to help you get some sleep. You're not typically suicidal when you're just having postpartum blues. If you're perinatal depression, yeah, I'm going to kill myself because I can't live like this. A problem. Because what's happening is, if you think about it, the cognitive distortion goes completely awry. Oh my God, it's going to be like this forever. Cognitive distortion, depression. It's not going to be like this forever. They're going to grow. They're going to sleep longer. Mom can plan. So that's how you can distinguish the two. There's no treatment generally required for postpartum blues. Just support them and allow for sleep, and it resolves on its own in a few weeks. Perinatal depression, antepartum depression, when you're talking true depression and it's causing functional impairment, that's the one that you do want to intervene for. So this might be something as like visiting nurse service can be a referral from psychiatry to just do well baby checks. Right? If you've seen the series called The Midwife, if you look at all the stuff they do there, a lot of that is more psych than anything. Well mommy checks, well baby checks, anticipatory guidance, respite care. If you have the resources, this new field has popped up called the baby nurse, Au pairs, if you've got the money, they move in, they take care of the kid, allow the baby to sleep, mom to sleep, and take care of all kinds of things.
She literally mentioned that she didn't take into consideration that she would actually have to take care of it.
Right.
And so for me, I'm like, me, and the same thing, because she didn't think that she already had it set up when she was home, that she was not going to care come and help
Right.
out. So in that part, she didn't think the 3 days that she was in the hospital.
The acute period.
She would have to take.
Well, what are you there for? Some of them have said, don't bring me this baby, feed him. I don't want to do this. Mm-mm.
Extra
Right. Some people do. And, you know, we live in a city where if you have the resources to do that, you can do that. I mean, the other backdoor approach for the au pairs, you could dial a nurse, have a visiting nurse come in for a couple of days. Going right for a private nurse in the home is anywhere from $120 to $150 an hour. You got the money, they got the time. So that's also a possibility, you know. So here is your diagnostic criteria for bipolar disorder. You kind of want to remember this as a crude way. Now, the question is, how do you diagnose bipolar? All of those checkoff tests that you have, those screening tools, are just that. They are screening tools. They're not diagnostic tools. In psychiatry, you are the diagnostician. So the way you diagnose is you do that complete history. You hit the 5 Ps, you're very systematic, you get an index of suspicion, you pick a focused screening tool, you may give them the test, and you look for functional impairments, you do collateral information, and then you write this thing called a formulation at the end where you show all the things you've considered, and you consider the support or lack of support for your diagnosis and differentials. That's kind of how a psych diagnosis comes to be, because we don't have biomarkers and brain scans, and those screening tools are just screening tools. So this is your option. So you're looking for things like distractibility, impulsivity, grandiosity, flight of ideas, activity, meaning goal-directed activity, less need for sleep, the speech is pressured and rapid, and they're talkative, increased verbosity. Now, this is the, I think I can fly, I'm going to start a project, I'm going to king of the world, what's that, a bird, you know, like that. And so you're seeing those symptoms, and those are the symptoms essentially of mania, right? Those are the mania symptoms. The reason we're screening for mania is because, and you'll ask this historically also, did you have a time in your life where, dig fast, right? Distractibility, irritability, because they may not be that way now in front of you. So before you go slapping them on an SSRI or an SNRI, you may want to elicit this. This is, you're the specialist now, right? Primary care say, SSRI, they don't ask these questions. You, specialists to be, ask these questions. Figure out, are you going to cause a treatment emergent affective reaction? That's, you know, when you give them the SSRI and they suddenly get hypomanic on you. Now, be careful, because you don't want to mask or misdiagnose the normal activation that happens with an SSRI as hypomania. Because if you do, then you're applying a very sticky diagnosis of bipolar 2. And we don't want that. It is normal for SSRIs to be activating, right? So when you start them, say, on Prozac or Lexapro or whatever, they may get dysregulated sleep because it's activating. This is why a lot of psychiatrists will go ahead and co-prescribe a benzodiazepine for the first 2 weeks, which I hate, of an SSRI to get you through acclimation. I don't recommend benzo. I recommend GABA or a second-generation antipsychotic, something like that, if you need to contend with the behavioral activation. Because the last thing you want to do is habituate a sleep disorder, right? We don't want to habituate that. So it's not uncommon to say start them on 10 of Lexapro and maybe give 300 of GABA for bedtime as needed if you're not able to sleep at night. Something like that. Or 12.5 to 25 of Seroquel if you can't sleep at night. Prozac comes already combined with olanzapine called Symbyax, and this was supposed to be for the depressed person who's got bipolar, right? So if they're seeing you in the depressed phase, you're supposed to start them on this Symbyax or this combination of SSRI and second-generation antipsychotic with the hope of treating both mood stabilization from the bipolar piece and antidepressant effect from the current depressed affective period. Now, we have a condition that's kind of like bipolar light. That's not bipolar 2, although bipolar 2 is the milder form. We have cyclothymia. And cyclothymic disorder is essentially this chronic mood with fluctuations between hypomanic and depressed symptoms, but it doesn't meet full diagnostic criteria for hypomania or depression. And it's mild, the pattern is long-term, usually the span of about 2 years. It's often under-recognized and misdiagnosed because people, depending on the mood or state they present in, by the diagnosis for that mood. But the history taking is often lacking, looking at predisposing, precipitating, perpetuating, and protective factors over time, right? Where is your functional impairment? That's what you want to figure out so you don't misdiagnose. They say this is greater than 2 years in adults, more than 1 year in child adolescent. Be very careful in diagnosing bipolar or cyclothymia in children. Be very careful because you are casting a lifelong die and you could be wrong. And you need to make sure that you are considering the family environment and this person's circumstances, and you need to be sure you're having a really good therapeutic alliance and you've dealt with malingering and factitious and the drugs, because everybody's on drugs, it seems. Please do not be willy-nilly with the diagnosis. Be very careful and systematic. So these people can go along fine because they found ways to deal with their symptoms either through avoidance, or they have the flexibility to have the sleep when they need it, or they can bounce from activity to activity with low consequences. And so that's how come it can fly under the radar for so long. The financially well-insulated can typically skate along with this disorder. Financially well-insulated, meaning high-resource people, can skate along. Here is bipolar disorder subtypes. So take a look here. It's about 0.3% of the population for bipolar 1. I'm sorry, for bipolar 2. Bipolar 1 is 0.4. Bipolar 1 is a little more common. That's because bipolar 2 is a little harder to diagnose. It's more subtle. It's easy to miss. So basically, you're looking for at least one full-blown manic episode, right? One, and that's it. And it can often alternate with major depression, but you may never meet them at that point. Typically, they come to care in the manic episode, right? This is the running down the street naked person. This is the one person we had who somehow convinced a taxi driver to bring him to New York from Michigan because he had a meeting with Mr. Chase. And so he wanted to go to Chase Bank to meet Mr. Chase. Now, I didn't know whether we should admit him or the taxi driver that brought him, because he was very upset and calling the police because he was being stiffed on the fare. Apparently, he kept the meter running from Michigan to New York. Another guy that starts to charge the General Assembly to go see Kofi Annan when he was the Secretary General to tell him that he had the secret to world peace. Suffice it to say, he came to psychiatry, right, in a manic episode. So that's how they typically come to care. If your mental illness does not affect those around you, it's likely going to fly under the radar. When you start to make it known to others, that's when you tend to come inside and someone says, hey, what's going on here? And how long has this been going on? And what else is going on? May require hospital. Often mania requires hospitalization, often. Hypomania, on the other hand, does not require hospitalization. You can treat this quite well in the community. Reason being is hypomanic people are sleeping. They're sleeping less, but they are sleeping. Not to say they don't get admitted. They do, but they don't have to be admitted. If they've got good support, collateral, they're willing to take meds, you have a good diagnosis, etc. It's less disruptive than mania. It's more subtle. They may present with a persistent depressive episode, but they may tell you about these elevated times in their life. But the problem is you're not going to get the, I haven't slept in 3 days and I feel fine. right? The bipolar one, I haven't slept in 3 days and I feel fine and I don't need it. The bipolar 2 is like, I need about 4 hours. Okay, so here is your grid to help you distinguish between bipolar 1, bipolar 2, and cyclothymia so that you can distinguish them. So all 3 are mood disorders. Bipolar 1 has a manic episode, which is required for diagnosis, and depressive episodes are common but not necessary to make the diagnosis. Bipolar 2, their hypomanic episodes are required along with at least 1 depressive episode. You can't diagnose it unless you know of these 2 distinct periods. Yes? Sure. And then the persistent functioning in cyclothymia, they don't have this major deficit in there that affects daily life. Bipolar 1 is the most high risk. 1 and 2 are typically treated with mood stabilizers, antipsychotics. Cyclothymia, you can do psychotherapy and really get at that habituated behavior, but likely they too are going to wind up on medication as well, because that's kind of our bias. So here we go with a problem called atypical depression. This is when depression does not look like what you'd expect it to look like. This is more common in men than women. So this is where you'll have the life sucks, I graze, take the edge off, gives me a serotonin hit. So I may be craving carbs and then I start to gain a little weight. I get stressed, I eat a little more. They typically will sleep away most of the day. Ugh, I don't want to go to work. I'll phone it in. The camera's off for the Zoom meeting. They really can't be bothered. Wake up in the morning. I dread going to work. I feel like I'm walking through quicksand. I don't really want to follow through on everything. Everything is a burden. They have intense reactions to perceived slights. They're hypersensitive. They don't feel like doing the romantic relationship. I don't want to meet with the friends anymore. They start to avoid things. Now, this can be constructed by some as a character problem, as a personality defect. This is the person that if you pay them a compliment, it does lift the mood. So for that reason, some psychiatrists see this more as characterological rather than a 2 depression. Life sucks. I love your shoes. Oh, well, thank you. And then the mood lifts briefly like that. Oh, you got your hair done. I see. Okay, good. So suffice it to say, this is kind of harder to treat because, like I said, the pills only work on biological symptoms. So you're going to have to find some biological symptom that will work with the what you're seeing. So the A motivation typically be something like bupropion or an SNRI, because the SNRI will curb appetite, so it'll get rid of this grazing behavior. The bupropion may cause some dopamine to give them some motivation, something like that. This is distinguishing from bipolar 2, mood reactivity and hypersensitivity. Atypical depression does not have hypomanic episodes, right? They may be labile and sensitive, but the hypomania is missing. Cyclothymia has mood lability, which is pervasive, independent. Atypical depression, their mood changes depending on the situation. Cyclothymia, it changes regardless and no tie to the situation. But in atypical depression, nice shoes. Oh, I feel better. Your hair's a mess. Oh, you hate me, you're a monster. See, all related to a precipitant. That's a way to distinguish it. Whereas bipolar or cyclothymia, that up and down can be regardless of the precipitant. Cyclothymia, grossly low energy, poor motivation, and concentration difficulties. In atypical depression, the symptoms are all secondary to their mood dysregulation. They may become irritable and leave me alone and that kind of thing. Atypical depression, the mood reactivity to positive events. So they report often physical symptoms and they get a boost with positive news. So I point this out just to help you distinguish the 2 different kinds of presentations for which you may see, and then you may offer treatment based on that. So you can make the diagnosis based on that. This is our criteria for major depressive disorders. And there is a mnemonic called SIGE-CAPS, S-I-G-I, sorry, SIGECAPS, SIGE-CAPS. And that is a mnemonic to see if you can tick off 5 of 9 of these symptoms, because if you hit 5 of 9, then you meet the criteria for major depressive disorder. And then you can qualify for whatever the pill happens to be indicated for. Symptoms have to be present for most of the day, every day, for at least 2 weeks, and it has to affect some sort of functional impairment. That's how we make this diagnosis of exclusion. You should memorize this as many ways as you possibly can so that you can be sensitive in your psychiatric interviewing for making this diagnosis. So depression has a clinical course, and there are various remission states. There's partial remission. This is improved symptoms. Some residual symptoms may persist. Continued therapy may be needed, or this may be where you decide to augment them with another medication to address the residual symptom. Oh, look, the sleep is now done with the mirtazapine, great, and you're eating, good, but you're still having a hard time concentrating, right? Your concentration is still impaired. So that might be where you decide to augment, say, with an SNRI. So venlafaxine, desvenlafaxine, duloxetine, something like that, because you've given them the mirtazapine, they're sleeping and eating, now we want to work on focus. They come back 3, 4, 5 weeks later and they say, you know what, I'm sleeping and eating, I'm focused when I do stuff, but I just don't have the motivation to start things. You say, okay, so now maybe I'll augment you with, say, bupropion, because that's the residual symptom. So now you have this California rocket fuel of bupropion, SNRI, and the mirtazapine, and then they come back and say, oh, great, I feel like doing things, I can concentrate, I'm sleeping and eating, let's keep that going for 6 to 9 months, let's get you habituated in therapy, and then we'll talk about coming off. When you start medication, you should always talk about a coming off plan. I feel like everybody should have the hope and the prospect of how we're going to come off, how we will know when we're going to come off. Some of the guidance is, are you doing the lifestyle and psychosocial interventions we keep talking about? And that's the goal. If you want to come off these meds, I need you in the gym 3, 4 times a week. You need to be meeting with some sort of social activity. We need to make sure you're hydrated, you're sleeping, you're attending to all of the things. When you start doing those things for 3 to 6 months, then we start to dial back the meds, and hopefully those things continue, and then we can gradually come off the medication. We don't live in a world like that unless you pay top dollar. And even if you do, it's just easier to come in and refill the meds and keep you moving through the system. So try not to make your patient into a perpetual professional patient. Try to offer the hope for them to come off medication. So essentially, we call you in full remission if you are symptom-free for 2 months or more. Symptom-free. All the things that you complained about are gone, and the functional impairments are resolved. Now, keep in mind, 6 to 8 weeks for these things to kick in. I need to habituate you for 3 months. That's a half a year is now gone. You tell me you're better for months 9 and 10. We can start to come off gradually in month 11, 12, beginning of the following year. Got it? That's kind of the progression of med start, gradually titrate, feel better, demonstrate efficacy, think about coming off, if you want to do this in a year. The psychotic features of major depression, which you should be very attuned to, especially in the elderly, which is typically when they manifest. People are not becoming schizophrenic in their 50s and 60s and 70s and 80s. They are likely having psychotic depression, and what you're seeing are the psychotic symptoms as more paramount. You do give them antipsychotics because there are mood stabilizing effects, but you do need to treat the primary mood disorder, so you do both. The psychotic depressions obviously have a higher suicide rate, and like I said, you may require both. So here are some age-specific presentations of depression. Children may manifest depression with irritability and angry moods instead of just simply sadness. Part of this may be age appropriate, but what you're looking for is a change in behavior. right? It's normal for 3-year-olds to have low frustration tolerance, right? Their norepinephrine has precipitously dropped off. They're supposed to smash it, right? That's normal. You don't bring them in for depression. So part of your job is to know what normal ages and stages are for growth and development, so you can provide anticipatory guidance so that you're not starting a 4-year-old on an antidepressant or a mood stabilizer, or like a wackadoo diagnosing them with bipolar disorder at 7 or 8 or 9 years old, right? You need to make sure that they're not intermittently explosive, oppositionally defiant. You need to make sure that the parents are consistent and persistent, and they're, you got to check the system rather than drug the kid. In child psych, they label the child the identified patient, right? Because it might be the symptom of a greater system. Somatic complaints are not uncommon in children. My stomach hurts. I don't want to go to school on Wednesdays. What happens on Wednesdays? I have a test. What happens on Wednesdays? I see that horrible teacher. What happens on Wednesdays? Billy steals my lunch money. Okay, so now you have a precipitant. I have a headache. I have a stomach ache. Why? Well, because when I come in, it's the only time I'm away from my mother, who's really stressing me out. So, okay, got it. So when you come to the hospital, you feel better. When you're home, you're feeling stressed. And all we changed was the environment. We didn't give a pill. Social withdrawal. I don't want to play with so-and-so. It's okay to pick best friends and things, but if they're withdrawing completely, that's a problem. Academic difficulties, you're looking for changes. If they were never the A student and they say, my child's not an A student, what was he? He was a B student, and what is he now? C's and D's. Now we have a change. But if he was an A student and now we're getting B's, that could be a big deal. But you want to make sure, is it B's because the work burden has suddenly gone up? Is it something that needs to be done with tutoring? Or is it lack of motivation, inability to concentrate, that they're not able to follow through? And then, of course, comorbidity with separation anxiety disorder. That's for children. Adolescents, yes, they have mood swings and irritability. But if I say, hey, rein this thing in, we don't have time for this, and they rein it in, and it's not spilling over, and it's not causing a functional impairment, normal versus deviation from normal. Risk-taking behaviors might be age appropriate, but at the same time, you have to realize subway surfing, bring them in. Buying drugs on the street, bring them in, because you need to have a sufficiently robust response to nip that in the bud. You realize it's normal for adolescents to rebel and test limits. So my anticipatory guidance for parents are this. You give them false choices. What do you mean? My son, he's 14 years old. I need you in the house by 9 o'clock. I know what you're doing, but I need you in the house by 9 o'clock because I want to go to bed by 10. Now, when he walks in the door at 9:15, I have the biggest conniption of my life, because I said 9 o'clock, it's 9:15, I'm burning this house down. He gets the reaction he's looking for. He rebelled. He's done now. Next time, he's always coming in at 9 o'clock because he got a rise out of me. Now, if he came in, he won't come in later because this was sufficiently jarring that he's no longer going to do that, and I still get to go to bed by 10 o'clock. Part of this is testing their limits. Right? Because I can follow him on the phone. I know where he is. He's standing in the lobby. Right? I know full well what this kid is doing. So I'm like, where have you been? You know you've been in the lobby for the last 15 minutes because I could see you on the phone. Right? And the doorman told me. And the people you were with called and said. And I know the whole story, but I need you to think I'm having a conniption so that you get the joy and success and satisfaction of the rebellion. Little Billy, who's 5 years old, we're leaving the park in 3 minutes or 10 minutes. Which would you prefer? 10 minutes. Okay, great. Either way, we're leaving when I want to leave, right? Those kinds of choices. Social media related issues and FOMO and cyberbullying, all of these things can affect mood in adolescence. So rather than give a pill, it might be helpful to disconnect and see if the problem resolves itself. Sleep disturbances, they stay up late, they wake up too early, they're not getting enough sleep. You just have to balance a circadian rhythm. If it's persistent, then you might have to medicate it, but we try not to. We try to do as much environmental as possible. Depression in older adults. This is where you get like an atypical depression sometimes. Older adults, like children, have a lot of somatic complaints. It's acceptable. They're going to the doctor for these things anyway. That might be the only place they get the psychosocial attention needed. They may think everything is a result of a deeper condition. So hypochondriasis might be a flare-up. I don't know why, but my elderly patients all get these delusions of poverty. They swear they're broke. I can't afford you. This is too expensive. I don't have this money. And I'm like, I think you can afford us. And the visiting nurse. Your butler let me in. This is an original Picasso hanging here. I think you can afford. No, 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 no. It's not worth anything. And you can't fight with it. So you kind of distract from it. You might medicate the depression and they might come along. They may not ever give it up, but they may not be as fixed on it. They may not bring up how broke they are at every visit. If you ask them, they'll repeat how broke they are. But if they don't bring it up at every visit and you're able to establish a good therapeutic alliance, that's helpful to do. The other major thing you need to do with the elderly is you need to screen for cognitive impairment and dementia because these are both occurring at the same time. Now, they may be anxious because they're aware of their cognitive impairment. However, that cognitive impairment may be as a result of the depression, right? So there's a reason that most neurologists, when they're treating dementia with their, acetylcholinesterase inhibitors, they will typically throw on some sort of SSRI, which I hate because it lowers the sodium, by the way. Then you have to chase the hyponatremia, and it's more common in the elderly. So my favorite SSRI in the elderly is vitamin Remeron because it stimulates appetite and gets it to sleep, which is what I want to begin with. And it doesn't derange the sodium, and neither does the bupropion. Those are the least sodium deranging. So suffice it to say, go after the depression, establish a sleep cycle, and make sure, and then retest to see if the cognition improves. And obviously assess for psychotic features and always suicidal, homicidal ideations and that sort of thing, okay? And get collateral. So treatment approaches for depression, non-pharmacologically, obviously all of those moderating factors we talked about, if you would just do them, like increase your exercise. This is the thing with no side effects unless you injure yourself. But this is the one thing that across the board boosts mood, stabilizes mood, enhances sleep, puts the eggs back in the shell, removes sexual dysfunction. It does everything. Exercise does everything. Weightlifting especially. Heavy weightlifting. That's great for neurocognitive, mild cognitive impairments, great for mood, depression, performance, and sleep. It builds a lot of BDNF because all of those pathways are being stimulated. It's stress, right? All of that. CBT is the big therapy that has the most support around it. It's the one that you can probably do most effectively. It's the one they're most familiar with. And then if you're really getting into it, family and group therapy to look at the perpetuating factors like the dysfunctional household you might have to contend with. Other therapies, interpersonal psychotherapy, this focuses on improving relationships and social functioning, because ideally, most therapeutic relationships lead to a relationship of codependence. We don't want that. Your job as a good psych NP is to work yourself out of a job. Like good parents, you're supposed to make yourself obsolete in that patient's life. You should not need me forever, ideally, when we're dealing with mood disorder. I want you to learn, or you should need me very little. You don't want to be a constant. Problem is, a lot of therapists, we got a light bill to pay. You're a nice patient. Let's keep you coming. Let's keep undoing. That's bad therapy, okay? They should not be in therapy for the rest of their life. So work on getting them out, self-sufficient, plugged in, moving forward, and you're out of work. Don't worry, there's more patients. So psychopharmacology is all theoretical, right? All of it is theoretical. We don't have good disease models. We can't do cause and effect studies. We don't know what normal neurotransmitter levels are. So what we're wanting to do in the patient, drugs only treat biological symptoms. I always recommend you go after the sleep symptom first, followed by appetite, then attention, motivation, and hopefully if you need to deal with the psychosis, you deal with that right up front. And they, by the way, all those antipsychotics are going to stimulate appetite and help you sleep anyway. So keep that in mind. This is a chart of the neurotransmitters here. The primary action on the body and the example effects of what you might notice. So the ones we're most concerned with in depression and anxiety are serotonin, norepinephrine, dopamine, GABA, and glutamate. You should know what those neurotransmitters generally do. We'll repeat them again in psychopharmacology. They are fair game for any test you'll take in psych. What neurotransmitters? So dopamine modulates pleasure and reward. Serotonin regulates mood, sleep, appetite, and pain. That's how come sometimes you'll give Zoloft adjunctively for back pain. That's why we give duloxetine sometimes for neuropathy. SNRI is good for alertness, arousal, readiness for action. GABA is inhibitory. This is like, think gabapentin, although it's not GABA, but just think gabapentin has the effect. It's a sedating, calming agent. And glutamate is the primary excitatory. Glutamate is excitatory. I say that a lot for a reason. You will be asked it in many settings. Okay, so those are the ones you need to really be familiar with. ECT, let's talk about ECT. How does it work? Exactly. But how exactly, why? We have no idea. But exactly right. It's therapeutic trauma, right? Trauma that you pay for. If we put a sign on the door, come here, I'm going to traumatize you therapeutically. What do you mean? We're going to talk about all the horrible things you've been avoiding. And I'm going to give you these pills, which your body will have to filter out. What? See, it's all in the marketing. You can't say it that way. If you were to put that on your shingle, no one would show up. Some might show up, but for completely the wrong reasons. So ECT is effective for severe and treatment-resistant cases, psychotic depression. It's a good first-line treatment. What you do is you treat it with the meds as well as ECT. You can get an initial bump right after the first treatment. TMS takes longer. Vagal nerve stimulation, I see it only on Facebook and the Instagram, and I don't know anyone that's doing it. Maybe research centers will also do it. But essentially, these are all basically things that are aiming at enhancing neuroplasticity. Okay, we're enhancing your brain's flexibility and adaptability for change, because your only option is change or die. That's all. Persistent depressive disorder. This is a condition that was initially in like earlier DSM-3 was a personality disorder. Not that we did any tests or anything to get it out of there, but it is a primary psych disorder. This is basically depressed mood for about 2 years, but no real functional impairment. It's just meh. So think about all the habituation that can occur here. So this chronicity is with depressed, persistent, low mood. There may be some functional impairment, but the thing is they don't rise to the level of bringing themselves to care. If they do come in, this is the person that you may diagnose with something called a double depression. So that is to say they're chronically low mood, but now they're really low mood. And so you treat the primary, and this is their baseline. Right? So you may feel like your treatment's not effective. It may not be as robustly effective as you want it to be, but it's effective enough to get them back to what it's normal for them. Right, their baseline, right. So this grief I added in DSM-5-TR, which is the latest edition, now has a diagnostic criteria for prolonged grief disorder. Now, this is a close relationship or a friend, somebody dies, and you have persistent grief if you're adult, more than 12 months, if you're a child, more than 6 months. How did we pick that number? We voted on it. According to American and Western European standards, that's all the time you're allowed to grieve. Now, this is different than grief and sadness because you're going to have at least 3 of the following symptoms. Identity disruption, marked sense of disbelief, meaning you're still in denial, which is that acute shock phase, which is basically stretching out. Avoidance of reminders, intense emotional pain, difficulty reintegrating into daily life, emotional numbness, feeling life is meaningless, or intense loneliness. You need to have 3 of those for the year to meet this criteria. Now, this can come in waves. The other side of it is there has to be a clinically significant distress and impairment exceeding your normal religious and cultural norms. But the problem is the DSM does not define what does clinically significant mean. So what they crudely say is if they come to you for care, therefore it's now clinically significant, because they would not come for care unless it was clinically significant. So that's how they define clinical significance. Exclusion criteria can't be better explained by other factors. and the symptoms have to persistently interfere with daily life. So here is the grid for you to look at and distinguish major depression from dysthymia, from prolonged grief, from atypical depression. I put it all up here side by side, and this I'll give you in the notes. You can have it. But basically, it's a quick reference guide for you to refer to. Now, disruptive mood dysregulation disorder. This is commonly diagnosed in children. Outbursts disproportionate to the situation, verbal and behavioral. It's chronic, it's irritable, usually between the ages of 6 to 18. If you're over 18, we're not diagnosing this. Okay, this is a young child disease. Typically begins before or around age 10. You have to be at least 6, though. What are we doing with these criteria? We're basically making sure that the developmental milestones have been met so we don't pathologize a normal growth and development. And you have to have the symptoms for at least 12 months in more than 2 settings, and it has to be severe in more than 1 setting. And not better explained by another disorder. And this was added to the DSM-5 because they were overdiagnosing children with bipolar disorder. This was what we call pediatric bipolar. The nice thing about this is it's not forever. You don't have to be on mood stabilizers. You can behaviorally treat this. Imagine, we don't have to put young children on antipsychotics. We are going to do violence, suicide, and abuse. Let's take a break now, and then we'll come back in 10 minutes, and we'll do violence, abuse, suicide, and homicidality. Welcome back. Welcome back. Welcome back. Here we go. We're going to start with violence, abuse, suicide, and homicide. Okay, so this is the risk evaluation that you are going to be often asked to do as a Psych NP. This gets very popular every time mass shooting breaks out. They want you to use your psychic abilities to tell if someone's going to do this bad thing, right? And so let's start with the most basic, interpersonal violence and abuse. This is defined as deliberate harmful actions within a relationship to exert power and control. Now, it can be physical, emotional, economic, sexual, etc. It's not an isolated incident. This is a pattern motivated by a desire for dominance and control, and it's often rationalized as love or care. It was the O.J. Simpson trial that thwarted domestic violence into the national spotlight. And ever since then, we now talk about it, and we ask people to do domestic violence screenings, and there's all kinds of social programs around this. What you need to be mindful of is you may be very tempted to tell the abused victim, well, why don't you just leave? Well, that's all good and well, and yes, ideally the person needs to leave because frankly, the abused person can only control their own behavior, not the behavior of the abuser. It is an unfair system. It's not, you can't make somebody do something. They have to be caught doing it. We are all presumed innocent, right? So your option is really to support the victim to help them get ready to leave. And when they're ready to leave, you will be able to help them. Now, why do I say that? Because the most dangerous time in the power dynamic is when the person plans to leave. Because the person with ultimate control, if you will, has realized they have nothing more to lose. If the person leaves them, they're losing them. And if I can't have them, no one else can. Right? That's the drama that unfolds. So they may then escalate and eventually kill the person. So you have to be very careful on your insistence. And, the first lecture we talked about motivational interviewing. You can only help the willing, and when you're ready, I'm here is your general guiding principle, not you need to leave, right? What you might need to say is, he hits me every time I don't get dinner on the table on time. Well, obviously, you need to leave, but you may not be ready. And my goal is for you to not get hit. So maybe you get the dinner on the table on time. Right? I'm just enabling. No, I'm trying to keep you from getting hit. So here's what I need you to do. We're going to play this game and tiptoe around, and we're not going to challenge him or her, because it goes both ways. and we'll do what we need to do. The way this goes when the male is the victim is typically the woman will use the children or something as a pawn in the relationship to help exert that control. And men typically will not report being physically abused by a female, and they will continue to show up with injuries that are incongruent. So that is something to be mindful of. I was surprised when I did sexual assault forensic exams to see how many male victims there were come in. I didn't expect it because I thought SVU was real. So not real. And very few sexual assaults are actually, grabbed in the alley and raped at gunpoint. Very few. I maybe have had like 1 or 2 in the 5 years that I did them. Most are acquaintance or, the person is known, and most happen within a mile of the person's home, actually. So that's something to look at.
Like the statement on the, there's a lot.
Oh, it goes both ways. Oh, yeah, no. I don't mean to be heteronormative. That's why I said he or she, as the case may be. Oh, that's very common too. Yeah. No, it goes both ways. It absolutely goes both ways. Basically, the common element in all of this is human beings. Human beings in general, be they male or female, gay or straight, have maladaptive coping mechanisms, personality disorders, can have antisocial personality traits. They can lack empathy. They can exert manipulative behaviors. They may have narcissistic traits. They may be exploitive. They may be emotionally labile and unstable. It's not unique to your gender orientation, preference, sexual identity, or any of that. This is normal to the human condition. So the power dynamic and dependence in the abuse, the personality traits can be a factor. You need to keep in mind, though, you can't diagnose somebody you haven't met. And a lot of bad therapists out there are diagnosing the spouse or partner of the person they're seeing. And what you need to keep in mind, while I believe you and I'm building therapeutic alliance, I have to remind myself I'm only getting one side of the story. You have to remember that, because these things don't happen in a vacuum. And there's always more to the story. So you need to keep in mind you're only getting one side of the story. A big part of your job, in this case, very discreetly, you need to get collateral information. Now, if it's a domestic violence situation, you're not calling the spouse to get collateral. Also, you always need to get permission on whom you're going to get collateral from. So you say, can I call your, in the children's case, the teacher, the coach, the other parent, the aunt, the babysitter, can I have their names and numbers, please? And you document them in the chart because they're in the chart, they gave them to you and you've documented the consent. It's not necessarily a form, but you want good, open communication with them. Also, you don't want to have couples who are in a domestic violence situation in couples counseling. It's actually a contraindication to couples counseling to have them if they're in domestic violence situation, right? And just the standard way that a couples therapy situation unfolds is in the first session, they're both together. And then in the next session, one, and the third session, the other one. And in the fourth session, you bring them together. And if it's sex therapy, what you're trying to find out is anybody actively having an affair that they're willing to stop. Because if you're actively having an affair and not willing to stop it, you can't do sex therapy. And the other side of the situation is you, the therapist, are now in on the secret and you're lying to the other person about it because it got disclosed to you. So that's going to really burn up therapeutic alliance. So in sex therapy, you're listening for an affair that's ongoing, that they're not willing to stop. And every once in a while you check in, the affair is stopped, right? That's checking, because if it hasn't, we need to stop. And so what you do in session 4 is you come back and say, this is not a good candidate for couples therapy, or this is not a good candidate for sex therapy. I recommend individual therapy for each of you, and you send them on their way. In domestic violence, what you're trying to figure out is, are you safe in your relationship? Are you physically or emotionally or sexually abused in any way by your partner? And if they say yes, then you come back in session 4 and say, I don't think couples therapy is right. You both should go to individual therapy, or coaching might be more palatable than therapy, but something where you can stoke insight, awareness, and hopefully have a behavior change, right? So This is not about the sex. It's not about the actual abuse. It's about the control. And there's often rationalization of the abuse. I do this because I love you. You know, you just make me so fill in the blank, right? You made me do nothing. Nobody makes you do anything. Everyone's responsible for that own action. In fact, I saw a sign today. What was it? Blaming other people for the path you're on is your own asphalt. Spelled A-S-P-H-A-L-T. But you get the point. You can't blame other people for the path that you're on. You need to essentially take responsibility for what is in your control and what is it you're willing to do, even if it doesn't mean leaving right now, and then plan and decide to make action. Okay. I have no pill for the abuser by you coming to see me. And no pill I give you is going to stop that from happening. So all I can do is support you, build a network, plan your exit, and when you're ready, we're here for you. Now, here's the other interesting thing. Abusers, and this is especially true in child abuse situations, where your caretaker is also the abuser, you love this person because they're all you know, and so you tend to normalize it, and you don't want to think outside that. And the other side of it, of course, is if you do treat, quote unquote, treat or remove the abuser, you're removing mommy or daddy, which in and of itself is traumatic, right? And then you get in the situation of the devil you know is better than the devil you don't know on some level. Or you risk going into the foster care system where who knows what happens there, because those turns out are not a bastion of comfort and security. Abuse happens there. And you have, you know, so there's bigger relational dynamics that go on. Yes, question.
Violent scenarios.
Meaning, who's the patient, the abusee or the abuser? The person being abused? Yes. Well, yeah, the precaution is that person may come after you if they perceive you to be a threat to their power. You have to be mindful of that. You also have to be attentive to if the abused victim starts to plot homicide. You have to be mindful there too, because you have a duty to warn in some states. And that gets to be a very sticky situation. Sometimes the way you can get around the duty to warn, it's not to say you don't do it, but maybe you involve adult protective services to create an intermediary, because that adult who's about to be murdered because of abusing this person is in a compromised situation. And so you need a way to bring in other services, be it police, social work, protective services, because the fear is if you call and say, hey, your girlfriend's going to murder you in your sleep, I have to warn you, well, then the girlfriend may be murdered in her sleep. So you have a problem there. So that's why it's really important to make sure you're involving sufficient support networks. And this abuse generally follows a cycle. Now, here's an interesting thing, it's a little bit of a tangent, and we'll cover it more when we get to narcissistic personality disorder. But suffice it to say, when the abusee meets the potential abuser and they're initially infatuated and everything is wonderful, they say, we have great chemistry together. Whenever someone tells you they're getting into a relationship and they say, we have great chemistry, before you cheer them on, your alarm bell should go off. Chemistry just means familiarity. There is something in this relationship I'm finding familiar, good or bad. And it may not be rational, but you're attracted to the familiar and you're comfortable with the familiar. And so you engage and continue in the relationship, which is how, you know, if there was a previous cycle of abuse and then the next relationship also has abuse and then the next relationship also has abuse, the only constant in that relationship is the abusee, the person being abused. If they're the ones coming for help, they're the only one you can help. Maybe you help them realize how we're picking the wrong person, right? It's not we're blaming, we're trying to empower, and I don't have any other way to empower you except to raise your own consciousness and say, stop chasing after these kinds of people. Yes? In case of children, yes.
If they on
parents.
Mhm.
Is it safe to separate them from parents? And, more
Who is the patient in the chair? The mother, father, or the child? Your patient is the child, and they report to you that their parent is abusing them. You are a mandatory reporter. You have to call Child Protective Services. If you do not, you could be in trouble professionally and legally. You have to report, and not to the parent. And it may mean call 911 and the kid goes to the hospital because it's a temporary safety net, and the social work gets involved, and APS goes to the home and they try to identify another family member, and that social work will make visits and that sort of thing. May not go right to may not go to foster care if they find another person that can care for the child. But that person has to be sure that that patient can be kept safe. So I'll tell you the only time in my career I've ever had to call Child Protective Services, which was really hard to do. I was treating somebody for addiction. And he was in addiction, polysubstance, treated sober for 6 to 12 months on Vivitrol, doing great. However, the wife was still addicted. And I knew they had children. And I said, you have a responsibility to protect those children from the addicted wife who's not in remission right now. And I warned the patients in advance. If I learn in our session that someone in your care is being abused or subject to harm, and you're responsible for protecting them, I need to report it. It's not personal, it's required by law. And he told me that the woman drove with the children in the car while intoxicated, got into a fender bender, and kept going. And I said, I'm sorry, but I have to call Child Protective Services after our session is over. And this is very hard to do, but I need to make sure that that kids are safe, because you are telling me you were not able to keep them safe. I'm not saying you're a bad person, but you were not able for whatever. Maybe she was abusing the spouse. I don't know. She could have been punching and hitting him. I don't know. But suffice it to say, and he may not want to tell me, just because he didn't tell me, it didn't happen. And so I said, look, we're going to call them. They came in, they did their thing, whatever, that sort of thing. Fast forward, this kid now is in therapy. Father is still sober. Mother is actively abusing the child, screaming at the child, unnecessarily being punitive, physically, et cetera, et cetera. The child tells this to the therapist. Child says to the therapist, I think my mom is drunk and high all the time. Therapist dismisses it as an instance of maybe you don't know for sure, and never reports it. So what happens? The kid continues to live in this environment. I can't call because I don't know. I've not seen the child. I'm getting a secondhand report. I don't know how accurate the report is. Remember, in the chair, you're only getting one side of the story. I don't care how good or bad the story is, you're only getting one side of the story. Part of being a scientist is you do have to remain skeptical. You can trust, but verify. And you have to be careful in how you verify. And if you can't verify, then you just kind of hold it as a provisional diagnosis until you have enough to make an accurate diagnosis, and at the same time meet your professional obligation as a mandatory reporter. So, types of abuse and interpersonal violence. Physical abuse. This is used to inflict bodily harm or intimidate. Examples obviously include hitting, slapping, pushing, choking, biting, often accompanied by threats of further violence. Economic is quite popular, especially in the elderly, where someone may be financially exploiting someone's resources, where they control their access to finances. They can restrict the spending, freeze the bank accounts, take them away from the credit cards, change the passwords. They create a dependency. The other way this plays out is where they medically neglect the person, where they don't let them get the medical care they need, or they engage in a factitious by proxy, Munchausen by proxy, where they may over or under medicate somebody. They may induce an unsafe environment that leads to falls. Those are ways that you can be attuned to this. I encounter this because I do house calls, and so I get to see the entire family in the living environment, and I get to talk to the pharmacy, and I run into all kinds of people. House calls is a very efficient way to cut to the chase and verify everything. Because I'm here, we're all here, this is how you live, I smell and see and hear everything, right? And so you can kind of cut to the chase that way. When they come to an office, they're putting on their game face, they're getting dressed, you're getting the protective, I'm here. Okay, I don't know what she came from though, but all I know is this snapshot in time. Psychological or emotional abuse, this is where you undermine, you're useless, you're worthless, you'll never amount to anything. Gaslighting, that didn't happen. No, you're wrong. I never said that. That's not true. Well, you only did this because public humiliation. This is very popular, emotional abuse from parents towards adolescents. So this you have to be very in tune to, because parents may not even see this as emotional abuse, but a parent commenting on the psychosexual development of their child is abusive because you're not protecting their privacy. For example, if you comment on your daughter's whatever, hair, bust size, weight, male genitals, broad shoulders, physical ability, those kinds of comments from parents are emotionally abusive. And they may not know they're doing it because it happened to them. And so their whole concept of normative is if I did it in my family and we pass it on here and nobody knows. So part of anticipatory guidance with parents is to say, unless it's abnormal, we don't really have to comment on it. And we're there when they come worried about, you know, when your daughter gets their first period, or they're the first one looking for a bra, or they have acne, or they're whatever. That's when you provide the support and the information. But unsolicited comments and advice on things that are immutable, especially, are not helpful. Okay, so just keep that in mind and attune to that. Any questions about violence or covert methods of violence? Victim vulnerability. So here we are talking about sexual abuse. So people in vulnerable positions. So obviously people in positions of authority. This could be a, a boss. It could be a teacher. It could be a peer. This could go on in the military. This could go on anywhere where there's a power dynamic and the person stands to control your ability to move up or live an undisturbed, unmolested life. And they're doing it really just to embrace their own sense of control. And look for things like rationalization. And if this goes on long enough, the victim will adopt the language of the abuser as a means of rationalizing it to themselves. And the reason they need to do that is that cognitive distortion and defense mechanism of denial is alive and well because it's protecting them. Because if I was not in denial, that means I'm being abused. And that means I am not so bright, not so strong, not so whatever to stop this abuse. So now I feel worse about myself. What kind of person allows themselves to be treated that? That's the inner dialogue. I'm not saying this, he's saying this out loud. That's the inner dialogue that might be going on, which perpetuates. It might be a lot of fear and shame and anger and resentment, and it's not coming out, and they're not changing their circumstances because they don't know how to contend with those kinds of emotions. This cycle of dependency in abuse relationships, it alternates between I love you and then abuse. You may notice things like what they call displays of kindness. So for example, horrible morning, bad yelling, screaming, fighting, come home with flowers or jewelry, right? That's a defense mechanism known as undoing. I'm trying to undo and erase your memory from what happened this morning, so I'm a good person. And so there's a concrete example of, I don't abuse you. Would I have bought you a golden diamond, blingy, whatever, would I have brought home these flowers? Didn't I take us out to dinner? Don't, that kind of stuff. All of that just and it's confusing. Why would he do this? Why would she do this? But this doesn't feel right. The other thing is there's this hopeless belief in the abuser's ability to change. Now, I do believe people can change. I do believe in forgiveness and moving on, but I also don't believe in we have to perpetuate, right? We don't have to walk into this eyes wide shut. We can take a very much trust but verify approach. Suffice it to say, the abuser can change, but there has to be sufficient internal motivation for that change. External motivators typically do not lead to lasting change. Okay. The other thing is the person may internalize and feel that they deserve this abuse as a reflection of their own behavior. And then you erode confidence and self-efficacy. The reinforcing factor, well, it's familiar, it's been going on for years, why stop now? Or if I leave, the children will be abused. That's a big one also. So people try to stay for the greater good of protecting the children, and in which case you try to keep people physically safe as much as possible. Okay. Intimate partner violences can go both ways between men and women. It's typically underreported when the male is the victim. The reason being is social stigma, lack of awareness. The healthcare system may minimize the report. So these are reasons that you should pay attention to the quote unquote atypical presentations of abuse and neglect, especially when the victim is not what you expect them to be, right? And the reason I make it heteronormative, which I did, but it does happen both ways, but it's more, most of the literature and most of what we're studying is heteronormative, right? The power dynamic likely exists in same-sex relationships, right? However, and it could be due to financial discrepancy, it could be to status, it could be to a host of factors, but in the grand scheme of things, the goal is for you to be aware that it can happen either place. So this is specific to the male survivor. Look for societal norms around masculinity, expectations of strength and control, and reluctance to report or seek help. This is the reason you may not see this occur. You may not see this person seeking help. There's also very limited services to men who are victims. New York City, you're fortunate. There's a lot of services for everybody in every specialty here. But if you happen to leave a greater metro area, you're kind of at loss. And there are not many, I don't know of any male-specific shelters for this reason. There are male shelters that are generally homeless shelters, but this person is in a vulnerable state, and all that's available for them may not be addressing that need, right? And then obviously fear of disbelief and ridicule, that is the primary reason for men underreporting. So what do you do for the abuse survivors and the perpetrators? So you may treat either of these people depending on your setting. So you have to develop a therapeutic alliance with your client, whomever they may be. So if you're dealing with the perpetrator, you're looking at things like challenging their irrational beliefs and developing empathy and recognizing and managing triggers of abusive behavior. This could be things like anger management, raising awareness. I just get out of control. Okay, let's talk about your getting out of control. Before you get out of control, what happens? Well, I start to breathe faster, my heart rate raises, and then something snaps, and then I snap. Great, let's work on identifying the earliest trigger. What's the first thing you notice? My breathing gets faster. Great. So when your breathing gets faster, what I want you to do is this breathing exercise, or leave the house, or go for a run, or something, right? You're trying to interrupt the cognition that leads to the feeling, or the feeling that drives the cognition that leads to the behavior. So that's the role of CBT, is dealing with cognitions and feelings and behaviors. Anger management techniques, addressing emotions constructively. Maybe you're feeling this way because of this. What came before that? What would happen if you didn't follow through? Are we getting to fear and shame in the abuser? Are they feeling slighted and this is their only way to feel, quote unquote, whole? Or homicide and violence. So the biggest risk factor is prior threats. The biggest risk factor is prior threats. The biggest risk factor for homicide is prior threats. I say that a lot for a reason. Past performance is usually indicative of future events, unlike the stock market, right? So another major risk factor is paranoia, preoccupation with weapons, idolizing violent incidences, and defiance of rules. So you see these antisocial traits. If it's just talk, it's one thing. The problem is when the talk escalates or is paired with one of these risk factors, then you have to be careful. If someone is threatening it, you ring all the bells, because you don't have a way to tell if they're lying or not. And it would be really bad if you minimized, and then it comes out, Well, he told the therapist that he was going to blow up the school, and the therapist didn't say anything, and here we are with a blown up school, right? So we should know. Escalation, when they start to make very deliberate threats against people, time, place, kind of like suicidality. As the lethality goes up, the plan gets more specific. So if you're hearing this specific plan, you know that's an escalation. Menacing gestures, they start lunging, they get aggressive, they start disassociating from reality. This is kind of a defense mechanism that kicks in so that they don't have to deal with the gravity of their situation. You may think of this probably as what a suicide bomber might do when they maybe go into a paratrance or something, and then basically they get this fixation on martyrdom and greatness and something after the fact. These are things that you may pay attention to should you happen to be in a situation where they are seeing you for a therapeutic purpose. Take all threats seriously, and obviously you want to notify authorities and get them into care or legal custody, whichever is most feasible. That is your role essentially in community psychiatry, is in keeping the public safe by doing good threat assessments and teaching others what to look for. School violence, harmful behavior, physical, emotional, psychological, in or around a school environment. Risk factors, which we've had since the dawn of time, include peer conflict, social isolation, firearm access. We had more in the olden days. Bullying, both victims and perpetrators are at risk. Now, I think the problem we're running into here is, how do you cope with it? My kids came home in 4th and 5th grade and said, there's no bullying in school. We think that's a problem. Why do you think that's a problem? Because nobody's really learning how to deal with conflicts. Everyone's just avoiding everything altogether. Interesting. My 4th and 5th graders came home with, they should bring back a little bit of bullying, so kids know how to act right. Because basically bullying is trying to conform to social norms in its moderate sense. It's extreme when you're trying to exert control over somebody else. If you think about it, the reason no one is sitting here actively picking their nose or in doing some sort of compromising gesture or being vulgar in any way is we have societal norms. On some level, this is a groupthink of bullying that's going on right now that keeps you inside the lines. Right? Societal norms are mild. So I think when they say bullying, that's kind of what they mean. But if you think about it, we're forcing you to do something that you may not ordinarily do. Now, if I break your arm, that's bad. That's bullying, horrible, right? But if I look at you like, please don't pick your nose sitting in my class like that, right? That's a different kind of forcing behavior by societal norms. So, and the other thing is people do need to learn to deal with conflict resolution more than just avoidance, because we have a very we have an avoidance society now. So rather than me telling you I don't like whatever, I just blow you up on a review site. Or I start a gossip chain around you and we do this social isolation. So the bullying has gone from fisticuffs to, which is predominantly female bullying, which is where alliances get formed and we isolate the person and we shun. That's how female bullying tends to unfold, because they do it by gossip and drama stirring and that sort of thing. Men will just pound, women will typically do this, but society is increasingly going towards the feminized way of doing things, which is essentially, we're not confronting anything, but we're going to socially isolate and limit. And the person's like, why is there nobody in my life anymore? For justified or unjustified reasons. Bullying may highlight gaps in social skills, encourage individuals to improve their interpersonal abilities, and navigate the psychosocial dynamics more effectively. Conflict resolution skills without immediate adult intervention can help develop essential conflict resolution skills in preparing individuals for future challenges. That is to say, giving them a script, helping them with the right words, what to do, that sort of thing. Because right now we have an over helicopter society where parent or teacher jumps in. Worse yet, the teacher doesn't go to the student, they come to me. I got a call during the pandemic. Your son is playing aggressive basketball. Did he hit someone? Well, no. But he's grabbing the ball from the other children and it's basketball. I think he's supposed to do that. I'm not an expert, but the dean is calling me. Mind you, my child is ginormously tall for his age, has been forever. He's 5'11", and he's like 13 now. but he's been ginormous. Like he towered over his teachers in middle school. And so I'm like, he's not being aggressive. He just can't see those little kids down there. Because A, the frontal lobe is not attached yet. So there's no cognitive processing. And he's, clumsy like all 11-year-olds are. And he's just tripping over little children, but they're in his grade. So I don't know what to say. Can you just speak to him and say, hey, just watch out for the shorter kids? No, call me in the middle of the day, in the middle of the pandemic. I'm like, what? I am trying to say, what? Do I have to come to school? Someone dying? No. Then send me an email. Goodbye. I bullied the principal, it turns out. But I didn't mean to do it, but I mean, like, I was like swab deep and they're calling on the phone and he's like acting like it's a 5-alarm fire. I'm like, so it's gone a little bit overboard. I'd rather just tell the kid directly, hey, knock it off. Good. Move on with your day. We don't do that anymore. Let's talk about suicide risk assessment. So suicidal ideation. So you're looking for specific intent, means, plan, and expressed hopelessness. This expressed hopelessness is kind of like the tell. This is the thing where this is probably my calculus for admission. If they're truly hopeless and there's no future and I don't see a way out of this, then what's the point? And in biding time, to me, that's my calculus for admission. I think that raises lethality quite a bit. The other major thing is substance use. Now, even if they're normally marijuana smoking or alcohol drinking, that is a big red flag for lethality because it can be the quote unquote liquid courage or the disinhibitor that gets them to follow through. So we need to be careful. That's why substance use is considered a major risk factor. We have the Columbia Suicide Severity Rating Scale. This thing got a lot of publicity. It's all the rage. All the schools have adopted it. All the hospitals have adopted it. In psychiatry, some settings, they have you do this at every encounter with the patient. Sometimes our job does come down to you have to check the box. So I'm not going to say yay or nay, but you have to check the box and assess for suicidality. And what it's looking at is wishes for death, thoughts of suicide, planning intent, and previous attempts. Past attempts are the best predictor of future attempts. That's the thing that really raises one's threat level. So documentation in abuse cases. So when abuse is happening, this is especially in a forensic setting. So if you find yourself working there, you need to be very comprehensive and accurate in what you write, because what you write is going to be used in an attempt to discredit you later. Okay, so you need to be very accurate in what you write. So for example, when I comment on the forensic exam that I do, I may comment on vulvar lacerations and whatever. And I just document that. I don't say due to rape, right? I just say due to patient reports, forceful penetration done. Why? Because that defense lawyer is going to say, could you sustain these injuries in any other way? Say, with consensual sex. Yes, you can sustain those injuries with consensual sex. Just the facts. You patient reports, patient states. Detailed observations, you want to comment on their level of distress in the setting, crying, tearful, reserved, guarded, impoverished speech, that kind of stuff. Comments about the treatment. So is this going to hurt? Patient is worried about pain. Patient is reporting sensitivity, those sorts of things. You're trying, because what you're trying to do is you're articulating a state of mind in words at a snapshot in time that will later be brought back to be interrogated. Victim statements, as much verbatim as possible. Descriptions of what they say the abuse was and their relationship to the abuser. As much of their own words. This is all in the subjective portion of your note. This would all be in the history of present illness portion of your note. And then collateral section is where you can document witness accounts, observations from others present during, what they tell you about the situation. So-and-so reports, friend of the person reports, like that. Best practices, cautious wording, avoid any assumptions and biased language, focus on the observable signs and symptoms, don't add any commentary or interpretation. Use objective descriptions, bruise on the left arm, or emotionally labile crying, alternating with stoicism. Confidentially make sure you secure all items if you're gathering any personal swabs. Limit access and prioritize survivor safety. So at the end of all this, Maslow's hierarchy kicks in. Crisis intervention work, if that's where you go, is aimed at basic needs first. Food, shelter, hydration, physical safety. That is crisis intervention work in mental health. and in anything for that matter. Any questions? Comments, concerns, suggestions, any online?